Thank you. So at the outset, I'd like to give a word of appreciation for the research team that lies behind some of the work that we're presenting today, and that's Bridget Johnston and Peter May in TCD, together with Fola Nichela, our research assistant, and Professor Charles Norman, who has provided us with mentorship and guidance over the years. So today we're going to talk on the topic of palliative care for the older person, considering data to plan for the future. So why this topic? Well, population ageing has been a global phenomenon since the 1840s. Although we tend to think about population ageing as an inexorable and continual improvement, it has of course been punctuated by periods where actually there have been steps backwards in terms of population survival. So if we think about World War II, or more recently the opioid epidemic in the US, or as Joanna pointed to, the potential effects of austerity, and of course the pandemic, which is very close to our minds at present. But generally speaking, despite these periods of pauses or perhaps some stepping backwards before moving forward, overall there has been a trend for older people to account for larger proportions of the population, and this is due to the combination of facts that they are both these people are obviously living longer, and there's a reduced birth rate in the general population. So the trend is such that it's considered a mega trend, that is one that affects society and the operation of society. Now, we've talked already a little bit, I think, over the morning session as to the balance between considering individual identity within considerations of service provision, and also then the practicalities of grouping people in terms of planning for services on a macro level. So with this in mind, I am going to use a definition of older persons as somebody being older than 65 years of age. However, of course, there is huge heterogeneity within the population, both because of characteristics, but even if you simply consider the chronology, one also can subdivide the population of the older person into the older old, together with those in the years closer to 65. So moving on to specifically the Irish context, just to remind ourselves, in 2017, the remaining life expectancy of a 65-year-old woman was 21.4 years. So a really positive story in terms of population ageing, and particularly when one focuses on the fact that actually living to older age can mean living in good health, and disability-free life expectancy is estimated at 13.4 years, which is actually nearly 2/3 of the remaining years of life. Men, as we know, have a slightly shorter life expectancy, with a remaining life expectancy there at 19 years, with also a shorter disability-free life expectancy. And we hear these figures so often, both in academia, in service planning, in the media, that in some ways I think we can almost become numb to them in terms of understanding. But if one considers the fact that the growth in the older population in Ireland has been so rapid and large in the last decade, that by 2028 there actually will be more people aged 65 plus in Ireland than there will be children aged 0 to 14. And I think when we think about Ireland as a country, we often do think about the family, the younger person. So that really is a very different picture to have in our minds. So moving to a graphical representation of this graph taken from the work of the Institute of Public Health, shows the proportion or the percentage of older people as a percentage of the total population. So we see here in the blue area of the bar chart, this represents the 65 to 74-year-old population. And then we have in the orange and green, we have the older age ages. And what we see there is that there's an increasing proportion of the population that will be comprised of those over 65, but the areas of greatest growth are those in the older population. And to give again an idea of the magnitude of the scale of increase, we are talking about moving from a proportion of the population of just under 15% in 2019 to nearly 22% in 2039. So very significant changes. Focusing on the topic of inequalities in health, we have heard about the fact that while some factors that shape health are genetic, the social, economic and political influences are ones that can have significant impact on health. And this is true for the older population as well. Indeed, many of the social, economic and political influences may have a cumulative or additive effect in older age. So if one were to look at one of the aspects, that is lower income, lower socioeconomic group, just under a half of people aged 65 plus in the lowest income group have a health-related limitation compared to just under 1/5 of those of the most affluent group in Ireland. So quite a stark difference, and accounting for an almost 5-year survival difference in those between the lowest and the highest socioeconomic groups. And indeed, for the older person, also influences such as social influences, when one thinks of older people and the impact of isolation or loneliness on health. And indeed, older people are also vulnerable, as we've heard, to housing effects. And those who live in rural areas, again, who live alone, are particularly at risk of experiencing housing inequalities with resultant impact on health. So turning to the topic of palliative care, are there inequalities that palliative care, with regards to palliative care for the older person? And unfortunately, it is indeed the case that there are. International evidence is that older persons can experience both inequalities on access, but also inequalities in outcomes of palliative care. And what do I mean by this? Well, older people have been shown in some studies to have reduced access to both generalist palliative care and also specialist palliative care. And this may particularly affect the older old. We have spoken, I think, in a number of ways on the subject of people with dementia. And people with dementia do have reduced access, particularly to specialist palliative care inpatient units or hospices. And while sometimes this may be an appropriate decision in the best interests of the patient, at other times it is because actually the environments are not age or dementia friendly. So somebody may have a complex need that may merit admission to a specialist palliative care inpatient unit for a member of the general population, but by virtue of challenging behaviour or perhaps prognostication difficulties, there may be a reduced access actually to inpatient units for people with dementia. And then even if people do access specialist palliative care, studies have also shown that older people can have a shorter duration of specialist palliative care input compared to the general population. Turning from inequalities in access to inequalities in outcomes, older people have been shown to have more untreated pain despite having a similar symptom burden to the general population. They may have greater unmet informational needs, and these could be due to a combination of factors such as cognitive impairment or issues of advocacy or gatekeeping. Older people, interestingly, have been shown to receive less emotional and spiritual support, and some of the thinking behind this is that clinicians or care providers may consider that a death or end of life is a natural part of the aging process, and therefore is one that doesn't merit as much support, which of course we know that simply because one is older doesn't make I suppose the experience of having a life-limiting condition or facing death necessarily any the easier. And also older people can be more exposed to unwanted treatment decisions, and that can be again either due to a lack of voice or advocacy, or perhaps because of impaired cognition, ability to participate in decision making. And while we sometimes think about the more interventional end of treatment decisions, you know, just to think on a day-to-day basis, older people being more dependent perhaps in aspects of care in terms of ability to be discharged home. How many times have we heard an older person saying that they wanted to go home, but we've been saying to them, oh, we are waiting on a home care package, or we're waiting on this to be organised or that to be organised. And older people can actually, you know, feel as though hospitalisation is something that they are restricted in their freedom or their ability to get home. So all of this really led us to focusing on the topic of understanding the needs of older people and preparing for the future with a focus on Ireland. And this UP study, as we call it, was funded by the Healthy Ageing Awards of Atlantic Philanthropies and the HSC. And the aims of the study are to generate evidence on current and future palliative care needs of older people, the magnitude and drivers of financial hardship among the seriously ill and their households, and what is required to effect change and deliver fair and inclusive palliative care services for older people. And in order to answer these research questions, we really have kind of our work organised into 3 work packages. The first work package, looking at the current and future palliative care needs of older people, we have conducted by looking at population projections using CSO, Central Statistics Office data, and TILDA data, which Peter May led out on. And an additional part of this work involves looking at those data sets, among others, including the Household Budget Survey, to further examine the needs of palliative care people in terms of service utilisation, experiences of care, and also the magnitudes and drivers of financial hardship. And we've combined those the access to those data sets within the administration of a bereaved carers survey, which I'll talk to you a little bit more about. And the advantages of routine data sets is that, you know, often they're well structured, they're population based, they have consistent ways of recording data. But of course, as we've also referred to, sometimes the data items that are being collected may not meet the full needs of the research question. And administering a bereaved carers survey, so a particularly bespoke survey administered to the carers of people who died within 4 to 10 months of service provision, can give us additional data, and perhaps in some aspects more granular data on particular questions of interest. And then the final research question, which is what is required to effect change and deliver fair and inclusive palliative care services for older people, we've aimed to answer by conducting a series of individual interviews with key stakeholders at managerial change leaders within the health system. So we've conducted just over 22 interviews looking at that. And we're currently in the process of analysis whereby we are combining our data to produce a final report, and we hope then to workshop the findings of the research with policymakers in the new year, and to engage with Voices for Care also. So I'm just going to give you a flavour of some of our findings with particular reference, I suppose, to the topic of inequalities. And so turning to some of the findings from the work package 1, that is the population projection data led by Peter. Well, rather than starting with our own work, I thought I would actually just place this slide up to give us a little bit of context. And because very often when we talk about planning at a population level, people will say, my goodness, but you're talking about tens of thousands, if not hundreds of thousands, indeed millions of people 10, 20 years into the future. Those numbers are just overwhelming. What does that really mean for me? That's something in the future. Well, data helps guide decision making, and what we have here is 2 pie charts illustrating the cause of the death by the principal cause of death, which was produced by the Health in Ireland Key Trends, the Department of Health. And on the left, the left, as we're looking at the screen, are the deaths by principal causes for those under 65 years of age. And then on the right-hand side of the screen, we have those over 65. And I just want to point out the different pattern of deaths that occurs between these two population groups. So starting with what is highlighted by the green arrow there, and that's accidental causes of death. So in people under 65 years of age, that comprises 15.7% of deaths, reducing to under 2% in over 65. Turning to deaths of resulting from diseases of the circulatory system, again, a big shift from 19% in the under 65s up to 30% in the overs. Even respiratory diseases, we see a change in pattern. And in this figure, respiratory diseases includes cancers of the respiratory system. So we have 14.6% in the under 65s, up to 21% in the overs. And then this group of cancers, we've heard a lot about the fact that specialist palliative care services still are largely configured around cancer care. Well, looking at the older person's population, there is actually a reduced frequency of cancer as the principal cause of death in this population. And indeed, we see a growth in the others, which includes neurological conditions and, of course, dementia care. So having an understanding of these issues at a population level, already you can kind of see how one needs to be thinking about how one might need to tailor pathways of care or the kinds of services that are being delivered according to age. So moving to our work, even very kindly introduced some of this in terms of referencing the fact that there is a body of work on population projections, and indeed Pauline Kane and ourselves conducted some of this some years ago. So why were we looking at it again? Well, number one, we were looking at it again because some time had elapsed and it was appropriate to update the projections. But importantly, number two, we felt that we could advance the methodology by combining the traditional methods of palliative care planning, which are based, as Even has said, on the recognition of the fact or the identification of a group of people that have conditions that are likely to be associated with palliative care needs, looking at how many people die with those conditions and saying, well, if you die of those conditions, then you are likely to have had a palliative care need in the last year of life, and then projecting those figures forward according to population changes. Well, that is very useful, but in essence, it does have a preponderance or an emphasis on, I suppose, the idea that palliative care is predominantly associated with end-of-life care. Even when one enlarges the concept to consider people who've been hospitalized in the last year of life, one still is taking one starting point from the identification of those people towards the end of their disease trajectory. Whereas, as we know, the paradigm of palliative care has shifted towards the idea of early integration from early points in the disease trajectory for those people with serious or life-limiting conditions. And so TILDA allows us to do that because, as mentioned, TILDA is the Irish Longitudinal Study of Aging. It involves a nationally representative sample of people over the age of 50 and involves interviews with participants every couple of years, and those interviews allow questions to be asked about the state of health, among other things, and resource utilisation. So this led us to carrying out two sets of calculations, and predominantly here we have the results from the figures where we're looking at the traditional paradigm of identifying those people who are likely to die with palliative care needs. And what we see here in terms of population projections is that there'll be an increase of approximately 68% of people who are dying with life-limiting conditions by 2046. So over a 30-year period, quite a steep increase. And as you'll see on the graph, the shift in population will be occurring in the older age population. So again, if people are expecting that our population will remain the same, it won't. It will be shifting upwards towards an aging population. But very importantly, if you start then looking at the population who we identify as living with a palliative care need. The line on the right, the red on the bottom, it represents those dying with a population with a palliative care need. And in 2026, we see that to be 28,000, about 2% of the population, rising to 42,000 in 2046, again remaining about 22% of the population. But look at that blue line going up into the sky. That's the total population of people who are living with a palliative care need over the age of 50. And what you see there is that actually in 2026, estimated to comprise nearly 300,000 people, rising to nearly 500,000 people in 2046. So a really big question for us here, if we are serious about the idea of palliative care for all, how do we actually deal with these populations? Because resources, there will always be a constraint on resources, and it is a case of us having to design systems to use our resources most efficiently. And how will we ensure that both people dying with a palliative care need and people who are living with a palliative care need have their needs met, and that the needs of one population don't necessarily displace or drown out the needs of another population. Also, some of the information that we were able to obtain from Tilda is of help in terms of resource utilisation planning, because we were able to look at what respondents would report as their disability burden, that is how many people report requiring assistance in their activities of daily living, or how many people experience pain. How many visits a person typically makes to a GP. In the year, ED admissions, inpatient admissions, how many people require assistance with home care packages at home. And what you see there is both for the people who are dying with a palliative care need and people who are living with a palliative care need, those patients or those people consume a disproportionate amount of resources, so which is understandable, because these people have needs, but as such, if they account, say, for those people dying with a palliative care need, who comprise about 2% of the population, they actually account for about 21% of the overall disability burden of the population, and 12% of ED admissions. So again, if we look at high cost and low value care, or care that isn't congruent necessarily with a person's needs or wishes, one might look at the idea of ED admissions. Now, we've heard from Joanna that people attend ED because they have a healthcare need, and that is absolutely true. But what we need to think about is, if the only door, as it currently is in Ireland, to much of an acute care and support is the emergency department, then we need to configure better ways of accessing acute health care for people that doesn't necessarily involve going to an ED, but supports them in another way. So some of the key points I take from this first part of the of our work are that where some high-income countries have already experienced their fastest rates of population ageing, this period is still approaching for Ireland. People age 50 plus living with palliative care need outnumber those in their last year of life by 11 to 1. Those people with palliative care need account disproportionately for resource utilisation, pain and disability burden. And we really need to think at a systems level how we need to design our healthcare system to meet those needs and allocate resources fairly. And while individualised needs assessment is absolutely essential part of clinical care, these numbers, these resource requirements are too great to meet on a one-to-one basis. This requires planning, and in order to plan effectively, we need to look at population-based planning, and we need to then think about where the demand's likely to arise, where the inequalities exist, what kind of and quantum of services are needed, and how should services be optimally configured to meet those needs. So moving on to some of the findings, or some of the work of Work Package 2, which involved, as I mentioned, looking at both data sets and a bereaved carers survey. Well, Again, I'm going to bring you through a couple of the findings that may be of relevance in terms of thinking about inequalities. So just a word about our Bereaved Carers Survey. So we have conducted Bereaved Carers Survey in previous work, that is the IR2 study, which was led by Erin Higginson, or the Community Palliative Care Study, which was awarded to us by the HSC also. And in each of these studies, they were looking at slightly different populations, either older populations who were frail, who didn't access palliative care, people who were getting community palliative care only, or in the UP study, we felt that we had opportunity to further add to the data set. So it's left us now with a data set of decedents who are greater than 65 years of age, who received either or both of specialist palliative care or older persons over a 3-year period in any of 8 organisations in 3 regions across Ireland. So a good data set to give us a little bit of a cross-sectional snapshot of care. And the same survey instrument was used to allow for aggregation of data, and we used a modified version of QualiCare survey. Further information we can provide on that as needed. And it looks at a variety of things, including demographics, ratings of symptom burden and experience, but the pieces I'll focus on are the use of healthcare services in the last 3 months of life and level of informal caregiving. So just looking at the demographics here, we have the demographics for those people, for the caregivers, who in essence, they're the ones in the green box there. So the caregivers were the people who reported on the survey. So they were issued a written survey, invited to participate. The survey was given about 4 to 10 months after their loved one had died. And the person then gave information and proxy reporting on the perspective of the decedent, and also then responses relating to themselves. So the majority of respondents were women, a slightly younger age, given that some of the caregivers were obviously adult children. And then the decedents, you'll see a majority were male, and the average age of those who had died was 74.9 years. About 2/3 were living with a carer, but 1/3 were not. And you'll see a little bit about the length of illness there. So a range of people with relatively shorter and longer illnesses. Now, we're not going to focus very much on the aspect of specialist palliative care service use today, but I do want to just highlight this table because I think it's illustrating what we need to consider a little bit more in terms of our service evaluation, and that is we cannot just talk about palliative care as a homogeneous mass anymore. We need to start breaking it up into specialist palliative care and generalist palliative care, and indeed then we need to start subdividing things within that. So even if one considers specialist palliative care, at a minimum it has 3 components, either hospital-based community palliative care or specialist palliative care inpatient, traditional hospital care, and you can have combinations of those components that patients have accessed. And we haven't even begun to talk about the quantum or the timing of service provision. So for example, if you record somebody had specialist palliative care, well, did they have 1 day of specialist palliative care 3 months before they died? Did they have 1 day of palliative care on the day they died? Or did they have 6 months of palliative care? So all of these things obviously will impact on outcomes and experience. So bringing you through a little bit of the findings here. Okay, so this gives us a snapshot of what formal services were used in the last three months of life. And what you'll see is our healthcare system is still hugely hospital-centric. So 85% of the patients having a hospital stay in the last 3 months of life. The service office people also access GPs, so key point of contact in the community, but really interestingly, public health nurses, arguably another extremely important care provider in the community. Only half of decedents accessed public health nursing. And then we come to the really sobering point where we look at access to health and social care professionals, and we are seeing that the figures are all 1/3 and below. So in terms of service provision, obviously not everybody who's in the last 3 months of life will need all of those services, but clearly there's huge underutilization of services there, or lack of access to services. So that would suggest some inequalities in access to services. Some people are accessing, some people aren't, and of course it will impact then on outcomes. And if we consider things like the fact that older people have higher incidence of mental health issues, because figures such as 3% accessing psychiatry is a concerning one. Also, I want to talk about informal caregiving. We feel that this is a really important part of our study that we're really going to be focusing and highlighting on, because informal caregiving is a critical but not always recognised part of caregiving. And informal care is obviously provided by the non-professional, that is the family members or friends of the person towards the end of life. And this, I suppose, for the first time begins this gives us a little bit more of a clearer picture as to the amount of informal caregiving that is provided by informal caregivers towards the end of life. So what we have here is we asked respondents to look at each of these items: time on call, household help, and rate how much, to give us how much time they spent on these activities, and then calculations were performed. So we were very conservative with the estimates. For a single carer, their caregiving hours were capped at 16 hours a day, even though arguably some don't sleep or sleep is interrupted, and to allow for the fact that I suppose sometimes you can be doing two duties at once, being on call and perhaps providing help at home. So there wasn't double counting as such. If there were two carers involved, up to 24 hours was allowed. And what you'll see here is, again, over 2/3 of people are involved in providing care to some degree in all of these areas. And the number of hours per week ranges from anywhere from 2.5 to up to 112, but with a mean of about 77 hours there, say, for time on call. So really significant amounts of care being provided. And to give an idea of what it would cost the health service to replace this care, we costed this at €30 an hour, which would be the replacement cost for the home help. And what that actually would amount to is very significant cost for the health service. Not to cherry pick findings, but actually there we have found an association in that the caregiving cost for those who receive specialist palliative care is lower than those who did not. But we are talking between 17,000 and 28,000 euros to replace that care. And we're currently now delving into understanding what might be the patterns of usage or what groups are providing what kinds of amounts of care and what kinds of care, and looking at things like, for example, those carers who have primary school education only are providing higher amounts of care than compared to those with higher levels of education, and people, interestingly, in urban areas are providing greater amounts of care. Does that say something about social networks and the lack of availabilities in rural areas? All of these things will need to be picked out further. Moving to the idea of unaffordable spending on healthcare costs, and I'm sorry I'm moving at speed through these final slides because I'm conscious of time. Well, this, just to give us a little bit of context here, because this is another thing that obviously impacts on both patients and the family unit. So unaffordable spending on healthcare is something that Bridget Johnston particularly is leading on this work, and this relates to an earlier publication where they looked at Central Statistics Office spending through the Household Budget Survey, and they looked at what determines unaffordable spending on healthcare. And unaffordable spending means either that you are pushed below the poverty line or pushed further into poverty, or that more of your 40% of your household spending goes on healthcare related expenditure. And what they did was they looked at who meets those definitions of unaffordable spending, and they looked at what might be associated with that. And they found that in 2009, 15.4% of the population were experiencing unaffordable spending on healthcare, rising in 2015 to 18.8%. But the piece to highlight is that older persons, again, is a risk for unaffordable healthcare spending. So reason for us again to look at this unaffordable spending, and this is just some of the domains of out-of-pocket spending, that is spending that's not covered by entitlements that can potentially push people further into poverty. And what we are seeing here is that again, there's a huge range of spending. And although some, you'll see there the range is from 0 to higher levels, 0 shouldn't be taken as saying, oh, these people aren't spending anything at all. The first thing to consider is that if you don't have the money, you can't spend it. So that may be indeed an unmet need. But the second piece is that smaller amounts for somebody who is poor push people even further into poverty. So again, we're going to have to break this down a little bit more to clear the message. But what we are seeing is that there's a certain level of protection afforded by things like the medical card in terms of spend on GP and hospital and carers and so on. But as Peter had alluded to earlier, there are definite areas where people are spending money that is likely to be excessively burdensome. And home modifications, and this doesn't include equipment, but home modifications, you'll see there that the average cost in the year of expenditure is nearly €2,000. So the key points from this are that service utilisation data is saying that our healthcare system is hospital-centric and largely biomedical. We're not accessing health and social care professionals, or we're not making that available in adequate numbers. Informal caregivers are providing crucial and considerable roles in care provision, and we need to understand better who needs more support and how we can provide it. And that the evidence is there that the healthcare system is protecting a number of people to a certain extent, but there are gaps in coverage remaining that we need to explore further. So pulling all of this together in our last 2 minutes, older persons in our interview data aren't typically viewed as a population with distinct palliative care needs or experiencing inequity by specialist palliative care providers. The exception is the population of people with dementia, but those people are recognised as actually more of a problem or a challenge in terms of what services should be provided, as opposed to something that people have a solution for. Specialist palliative care providers, I'm afraid, despite all of our years of change, remain much more confident of our ability to provide care to people with cancer or care to the imminently dying, which is going to provide us, pose us with even greater challenges as we experience the demographic shifts. Integration of models of care is hugely needed, but at a managerial or service provision level, that actually hasn't happened to the degree that is necessary. So the final thoughts are that universal health coverage means that all people should have access to health services they need, when they need them, where they need them, without financial hardship. And we're adopting in Ireland a population health management approach as a key enabler to delivering on nostalgia care. And population health means you start from the perspective of understanding groups of people rather than just looking at the illnesses, and you use the data then to understand what factors are driving poor outcomes in different population groups, and you design or redesign your models of care around that. So although we are recognised as a world leader in palliative care, we can't rest on our laurels, because I would say that arguably some of our greatest challenges may lie ahead if we are really serious about delivering palliative care for all. And our traditional sense has been an individualised needs assessment, but we also need to consider population-based assessment, and we need to consider accessing or collecting data that will enable us to move to this. So although in some respects the demographic challenges may be stark and population planning may have been overwhelming, I leave you with some practical final suggestions. I would suggest that we should update the minimum data set immediately to allow for linkage of CPC, IPU and hospital data. That would be helpful, and Peter and his colleagues have some further suggestions in the publication only last week below. We need to use our existing data sets to conduct analysis at regional levels, and we, the palliative care community, need to do that. And we need to then start focusing where there are high cost, low value or clear inequities in care, and we need to strategically prioritise those areas to define, design and deliver. And really importantly, we need to be the ones looking outwards and proactively engaging with the integrated care programmes, because there was a sense from the interviews that unfortunately that degree of integration hasn't happened to the degree that is necessary. So thank you very much. Acknowledgements and funding listed below. Thank you.
Thank you so much, Karen, for a highly interesting and informative and thought-provoking presentation. I'm sure I'm not the only one who's trying to take it all in, some of the stark facts and figures there. I've got a question from Maria Pierce. Could you explain what the distinction is between dying with and living with a disease indicating a palliative care need? Thank you, Maria.
Yeah, so in all honesty, the phrase is something that we used almost within the research paper. So to I suppose, to differentiate between the traditional group that people have planned for in terms of population projections, because they were easily identifiable. You start with a death cert and you can identify who died and you work it forward. But it's been harder to identify who are the group of people living with palliative care needs. So to be honest, that is an artificial construct. And if I was looking at a patient in front of me, I wouldn't be talking about, are you dying or are you living? Because as we know, palliative care philosophy is to live life to the fullest, at all stages of life, if that's of help in clarifying the issue. Thank you.
Yes, thank you, Karen. Can't see any other questions, but I suppose for myself, what are your plans, Karen? And obviously I'm biased in this question, but what are your plans in ensuring that the findings from your research impact on policy and practice?
Yeah, so as a core part of the research project, we did look towards the idea of dissemination. So we've partnered with the Institute, and so we have a website which is fantastic that Kathy has put up, where at the moment we have some of our findings, and we'll obviously be adding to that more in the coming weeks as these things are put forward. We held one meeting of engagement with Voices for Care, which unfortunately was I suppose a beginning, I would say, rather than as much as we would like. So we are committed to bringing that further forward. And as mentioned, then we hope to hold a policy workshop with funders and with service providers and relevant stakeholders to then workshop some of the findings and to try and, I suppose, see what might be of use in terms of the upcoming policy update for palliative care, and what might be of value for services in terms of considering their own service planning and adaptations to services. And any other more suggestions welcome, of course. We're always happy to engage with people, and I think something like the PCRN is such a valuable structure in that respect, that people should really feel that they can email, reach out, and we'll do our very best to engage. Thank you.
I know from my own perspective, your research is coming at an excellent time, and in terms of the development of the new palliative care policy for adults in the Republic of Ireland. So it's and I know that the bulk of the work is going to be kicking off on that early in 2022. So good timing there.